Hello, in this podcast we're going to be talking about nystagmus, which is an eye movement disorder which is quite common in children with Down syndrome. So nystagmus means that the eyes move beyond the control of the person, usually in a to and fro movement. Rarely there might be a vertical movement or a mixture of the two, and in extremely rare cases the eyes could even go round. But let's not worry about that at the moment. What I want to do first of all is just talk about the different types of nystagmus, and I want to start with the types of nystagmus that you don't have to worry about. So the first one is voluntary nystagmus. It turns out that about 8% of the adult population can actually make their eyes wobble. The eyes move extremely quickly and only by a small amount, but it's actually more of a shudder. People that can do it find it tiring, so they can only do it for a few seconds. And some babies can do it. Now, what we don't know, and what I would really like to find out, is whether the babies that can do it actually go on to be the adults that can do it. Among adults, it's a bit like a party trick. People that can do it will tell you that they have to tense their muscles in some way. Different people do it differently, but it involves an effort to tense your muscles, and then the eyes very, very quickly wobble. In babies, it's often referred to as voluntary flutter rather than voluntary nystagmus, and a surprising number of babies do it. It's not more common in children with Down syndrome than it is in the general population, but it gets reported more commonly in children with Down syndrome because you, as parents of a child with Down syndrome, are primed to worry. If a child who is typically developing has voluntary flutter, then nobody worries. You see it and go, oh my goodness, did you see that? He can make his eyes wobble. Isn't that funny? But if you have a child with Down syndrome, you are so alerted to all the horrible things that can go wrong, most of which probably never will in your child, that you look at every unusual happening and you worry that it's the start of something significant. But voluntary flutter is not significant. Babies do it when they're quite tiny. Sometimes you can actually see them tense their muscles when they're doing it. So rather like the adults who do it, it takes a bit of effort, but it's probably not voluntary. They're probably not thinking, oh, now I'm going to make my eyes wobble. It's probably just something that happens when they tense certain muscles. So some babies do it when they're about to start feeding. The spoon comes towards their mouth and they tense up in excitement and their eyes wobble, and parents, of course, then worry about what on earth is going on. The children stop doing it as they get older, but as I said, what I would really like to know is whether those children do go on to be able to do it voluntarily as adults. So, if your child can do voluntary flutter, and it's a very fast, quite small movement that just lasts for a few seconds, it's absolutely nothing to worry about. But if you are concerned and you want a second opinion, then take a video of it and show it to your GP, your paediatrician, the ophthalmologist next time you're at the hospital. Take a video, because the chances of your child actually doing it while a professional is watching is extremely slim. So at least the professional will know what you're talking about, or just send me a video. So the next type of nystagmus that we don't need to worry about is called end point or end gaze nystagmus. Now, I'm going to turn and look at the camera with my eyes in an extreme position, and you could do the same. You could look at the screen now with your eyes turned to one side in an extreme position, so much that it hurts, and you'll find that you simply can't hold your eyes in that position. And what then happens is that your eyes move to the position, come back again because that's more comfortable, go again, come back. So your eyes do have a bit of a wobble when they're in that extreme position. Some people don't have to move to quite such an extreme position before their eyes start doing it. But in either way, it's something that almost everyone has if you push them hard enough, and it's nothing to worry about. And the third one is, well, it doesn't have a name, so I'm going to call it not quite getting it right yet nystagmus. And this is a little wobble of the eyes when your child looks from one direction to another. So your child moves his or her eyes, and as they get to the next thing they want to look at, their eyes just have a little wobble and then settle down. That just means that their system hasn't learned to get it quite right yet to make precise eye movements. They don't get to quite the right place straight away, so they have a little wobble to get there. And again, it's something your child will grow out of, so don't worry about it. But again, if you can, take a video. That will help you discuss it with the professionals if you are concerned. So that brings us to the type of nystagmus we do need to be concerned about. So let's call it proper nystagmus. And in proper nystagmus, that's my term, by the way, not an official term. Proper nystagmus usually comes on when a child is within the first few weeks of life, and it's called infantile nystagmus because it comes on in infancy. It doesn't come on when children are older. So if your child is over the age of a year and they don't have nystagmus, they're not going to develop it. So you can just stop listening to this podcast now. Infantile nystagmus means the eyes move most of the time. Sometimes it can be sort of occasional, or it's more obvious at some occasions than others, and your child doesn't seem to be able to control it. As I said earlier, it's usually to and fro. And if you watch the eye movement carefully, you'll see that it consists of two movements. There's a slow movement away from what your child is looking at, and then a quick snap back. The eye may go slowly in this direction, snap back. It may go slowly in this direction and snap back. But it's doing it quickly, so sometimes it's a bit difficult to know that there are two phases to it, a slow drift away and a quick snap back. But that type of nystagmus is always associated with a visual impairment. And there are basically 3 types of infantile nystagmus. There's what has been called sensory nystagmus, which is associated with a diagnosed visual impairment. So a lot of children that have from birth a visual impairment caused by their eyes not developing properly or whatever, then on top of that they are very likely to have nystagmus. And then there's latent nystagmus, which is a nystagmus that only appears when you cover one eye. So your one eye is covered and the other eye starts to move in that nystagmus fashion. Sometimes there can be quite a long delay between covering the eye and the eye starting to move. Sometimes the eye will start to move straight away. Latent nystagmus is almost always associated with a squint. So it's involved, we don't really understand what causes any form of nystagmus, but latent nystagmus involves a breakdown of the binocular system, the ability to use both eyes at the same time. In latent nystagmus, the eyes will be perfectly steady when the child has both eyes open, so they won't have any visual problems as long as both eyes are open. But if you cover one eye, latent nystagmus starts and the vision will drop. So children with latent nystagmus absolutely hate having one eye covered. But we need to be sure that teachers don't ask that child to cover one eye. There aren't many instances, particularly when children are young, when they might be required to cover one eye. The only one I can really think of is if they've been allocated the role of pirate in the school play. And we need to let the teachers know that that's not appropriate for the child. They're going to get upset if you ask them to wear a patch on one eye, and they have a genuine reason for getting upset. It's not just that they're having a sulk because they didn't want to play a pirate, they wanted to play Captain Hook, for example. So we need teachers to know that. Latent nystagmus can also break through, we call it becoming manifest, if a child is very tired or ill. So again, we just need teachers to know to be on the lookout for it. And the third type of nystagmus is called idiopathic. And idiopathic is a medical term used in lots and lots of areas that means we have no idea what's causing it. And we have very little understanding of what causes nystagmus in either the sensory or the latent form, let alone the idiopathic form. But it just means that the doctors cannot put their finger on what might have brought about nystagmus in this particular child. And it is the most common form of nystagmus. And it is the form that almost all children with Down syndrome who have nystagmus have. Okay? Any child with nystagmus should really undergo comprehensive testing to determine whether it is idiopathic or whether it is due to a visual impairing condition that can be separately diagnosed. And children with Down syndrome should really be treated the same as other children, although the chances of a child with Down syndrome also having a visual impairment is very, very small, the recommendation is that all children should be given a comprehensive suite of tests to rule out any of the other causes of nystagmus before it simply gets labelled as idiopathic. Now, if your child has nystagmus, it does mean a visual impairment. We know from lots of research that any child who has nystagmus doesn't see as well as a child who doesn't have nystagmus. And we also know that children with Down syndrome without nystagmus don't see as well as children, typically developing children without nystagmus. So a child with Down syndrome who also has nystagmus has a double whammy. They have a reduction in their vision that is due to Down syndrome and a further reduction in their vision that is associated with the nystagmus. So it's very, very important that everyone knows about the impact of vision, on vision, of nystagmus in a child with Down syndrome. Nystagmus is not part of Down syndrome. If a child has Down syndrome, they are at higher risk of developing nystagmus, but it's not part of the syndrome and it needs to be managed properly. And that means referral to your local VI service. Every educational authority in the UK has a service dedicated to the education of children with visual impairment. And the teachers involved in that service are known as qualified teachers of the visually impaired, or QTVIs. Now, the name of the service may be different in different areas. Sometimes QTVIs are part of the sensory team. Sometimes they're part of the special educational needs team. Sometimes it's called the pupil support team. But wherever you live, there will be a team of QTVIs who look after the children in your area who have visual problems. The role of the QTVI is not to teach the child, but to teach the teacher how to modify material and modify experiences for the child in their classroom who has a visual impairment. It's crucial that if your child has nystagmus, they are referred to the VI team. It is the responsibility of the hospital at diagnosis to do that. So when your child has the diagnosis, you should insist on a referral to your local VI service. And the hospital will know what that means. QTVIs support children before they go to school. It may be that your child and you don't need much support, or it may mean that you do welcome a bit of support, a bit of reassurance, a bit of extra knowledge, and that's what the QTVI team are for before the child goes to school, to support you. And then once your child is at school, their role is to support the teacher and the classroom assistant. Schools can also refer to the QTVI, so if your child has missed the boat, already in school and they haven't been referred, then insist on the school referring your child with nystagmus to the local VI service. Right, let's talk a bit about the impact of nystagmus on your child's vision. And I've said that your child's vision is poorer, partly because of Down syndrome, partly because of nystagmus. And by that, I mean their detailed vision. How far down a letter chart they can get is poorer than a typical child, or poorer than a child with Down syndrome without nystagmus, and that's called visual acuity. Of course, your child may not be using a letter chart if they're still quite young, but we have a variety of different tests to allow us to measure the same thing in a child that's not yet ready to read a letter chart. So we will know what the equivalent is for your child. Contrast may also be affected by nystagmus. So big and bold is the byword for helping a child with nystagmus, but there are other considerations as well. A child with nystagmus is slow to see. And you can understand why. If your eyes are moving all the time, it takes you a long time to get your eye to where you want it to go, to look at a picture or a word and so on. And you can imagine reading, if you have nystagmus, trying to move your eyes steadily along a row of words. So it takes a child with nystagmus much longer to carry out a visual task than a child without nystagmus. So teachers need to understand that. Nystagmus is also highly variable. It varies between individuals, how much or how fast the eyes move, but it also varies within an individual. So if your child has nystagmus, you will probably know that when he or she is tired, their eyes wobble more. They also wobble more when your child is under stress, and they will wobble more when your child is not feeling well. So if your child is about to go down with a childhood illness, you may notice that their eyes wobble more. And of course, the more their eyes wobble, the poorer their sight is going to be. So it's really important again that teachers understand that your child may not be able to work so well in the afternoons at school as they can in the morning when they're fresh and raring to go. And of course it may be the other way round. If your child was up late last night, their vision may be much poorer in the morning and so on. So the teacher should really get to know the child's habitual eye movements, and if they appear to worsen, it's a good signal to the teacher that your child needs a rest. Now, another feature of nystagmus is that it varies with the position of the eyes. So the eyes may wobble more when the eyes look in certain directions than in other directions, and the child might have a position of the eyes where the movement is least, and therefore their vision best, and we call that a null point. And the null point could be anywhere. So suppose your child has a null point which is looking to his or her left hand side, then obviously when the child wants to look straight ahead, he or she is going to turn their head so the eyes are in their best position. Similarly, a child might put their chin down because their nystagmus is best when their eyes are looking up, They may put their chin up because their eyes and vision are best when their eyes are looking down, and so on. The null position can be anywhere. But it's very important that the teacher understands why the child appears to hold their head in a strange way, and we don't want members of the family or teachers telling their child to sit up straight. Turn your head towards me when you're talking to me, because there's a very good reason why the child adopts this abnormal head posture. If the head posture is extreme, if the child habitually has their head in a very extreme position, then obviously this will have implications for the development of their neck and shoulder muscles and their comfort. So for some very rare cases, surgery on the eye muscles to move the null point to straight ahead, or as close to straight ahead as you can get it, might be advisable. So if your ophthalmologist suggests an operation for the nystagmus, discuss that with him or her, because there may be a very good reason why your child would benefit from that. Okay, one more thing I should have said at the outset and forgot is that very strangely, some babies with Down syndrome who have nystagmus grow out of it. Now, as far as I'm aware, this doesn't happen in typical babies who have nystagmus, but I've seen it a few times in children with Down syndrome. A child a few weeks or months of age may have a very noticeable nystagmus, and by the time I see them a second time, it's disappeared. Who knows? So, if you have a very young baby and you have seen nystagmus, the hospital staff may tell you it's nothing to worry about, and you might feel they're being dismissive. It may be because they know that your child has a chance to grow out of it. But if your child is over the age of 1 year and they haven't grown out of it, then they're not likely to. So now the hospital staff should be taking it seriously, and you should be insisting that they do so, that they refer you, for example, to the local VI team. And I think that might be all I have to say about nystagmus. You know how to contact me through PADS or over email if you need to ask me anything else. There are, of course, plenty of people who achieve wonderful things in spite of having nystagmus. So the key is getting the child the appropriate support in school and everyone understanding what nystagmus means and what impact it has, and compensating for that. And as long as that takes place, the nystagmus should not hinder your child's development at all. Okay, so having said that, thank you very much for your attention. See you in another podcast.